Welcome to the deep dive. Today we're going to tackle something that, well, it affects a lot of people and can really mess with their mobility. Leg pain when walking. It's because of narrowed arteries. We're talking about intermittent claudication, specifically caused by aortoiliac peripheral artery disease, or PAD.
Yeah, PAD. Basically, your legs just aren't getting enough blood when you're moving around.
Exactly. When you need it most.
And if you're dealing with this, you're probably wondering, okay, what do I do? Usually doctors look at medication, lifestyle changes,
Right.
structured exercise programs, and sometimes procedures to like open up those blockages. Stenting is a common one.
Yep, stenting. And that brings us right to the heart of our discussion today. We're diving into a really interesting study. It's called the CLEVR trial.
Ah, CLEVR.
Led by Murphy TP. It's an acronym, stands for Supervised Exercise, Stent Revascularization, or Medical Therapy for Claudication, due to Aortoiliac Peripheral Artery Disease. That's a mouthful. It is. It was published back in 2015, Journal of the American College of Cardiology.
And what CLEVR really wanted to figure out was, how do these different approaches stack up over like the longer term? They looked out to 18 months, specifically for people with PA affecting those main arteries, the ones in the abdomen and pelvis, the aortoiliac ones.
Right. So for you, the listener, maybe you want a really solid grasp of this. Our mission today, break down CLEVR.
Yeah, cut through the jargon.
Exactly. Cut through the medical complexity, focus on what the science actually tells us about managing this. Okay, so let's just jump in. Why aortoiliac PA? Why focus there?
Well, that's a really key point. See, aortoiliac PA involve those bigger arteries higher up.
Okay.
They supply blood to a really large amount of muscle mass in your legs. So blockages there, they often cause more severe symptoms, more limiting pain.
Makes sense. Bigger pipe, bigger problem if it's clogged.
Precisely. And also, when doctors do procedures like stenting up there in the aortoiliac area, the results tend to be, well, more predictable.
More durable.
And more durable, exactly, compared to working on smaller arteries further down the leg. But even knowing that, there was still this question mark, what really works best long-term for these patients? Meds, exercise, stenting. That uncertainty is what CLEVR aimed to tackle.
Gotcha. So the study design, how did they actually run this thing? Okay, so CLEVR was set up as an observer-blinded, randomized, multi-center trial.
Right. Lots of terms there.
Yeah, let's break it down. Randomized means patients were assigned by chance to one of 3 treatment groups. Multi-center means it happened across 22 different sites in North America.
Okay. And observer-blinded.
That's important. It means the people assessing the patient's walking ability and symptoms, they didn't know which treatment group the patient was in. The patient knew, obviously, but the assessor didn't.
Okay. Helps reduce bias in the result.
Exactly. Keeps it objective.
And the 3 treatment groups were?
Okay, first, optimal medical care, or OMC. Think of that as the best standard medical treatment available then.
Second group got OMC plus Supervised Exercise, or SE.
Okay.
And the third group got OMC plus Stent Revascularization, or ST.
Stenting. Got it. Now, I noticed you mentioned the groups weren't the same size.
Yeah, that was interesting. They actually put twice as many patients into the stenting group and the exercise group compared to the OMC group. So a 2-to-1 ratio.
Why'd they do that?
Well, the thinking was that the difference between, say, exercise and OMC, or stenting and OMC, would likely be bigger than the difference between exercise and stenting themselves.
Okay.
So they needed fewer people in the OMC group to still see a significant difference when comparing it to the other two. They also stratified things.
Meaning?
They made sure the groups were balanced based on geographic location and whether patients were already taking a specific drug, cilostazol.
Okay, cilostazol, common for claudication. Got it. All right, let's dig into these treatments. What did supervised exercise actually involve? Sounds intense.
It was pretty structured. Participants went to exercise sessions 3 times a week for an hour each time. And this went on for 26 weeks, so about 6 months. All the sites used the same exercise plan, kind of a common protocol, and there was oversight to make sure it was consistent.
And did it stop after 6 months?
Well, the supervised sessions did, but the support didn't entirely. For the next year, so months 7 through 18, they got follow-up phone counseling.
To keep them motivated.
Yeah, basically to encourage them to, keep up with exercising on their own.
That's a serious commitment.
Yeah.
Okay, what about the stent group? What did that procedure look like?
So in the ST group, the aim was to put stents into any significant blockages defined as more than 50% narrowing in the aorta or the iliac arteries.
The main ones.
Right. They used approved stents and things like antiplatelet meds, aspirin, clopidogrel. That decision was left to the doctor treating the patient.
Okay.
It's interesting, only one patient actually got a stent in the aorta itself, and nobody had procedures done further down the leg at the same time, like in the femoral artery.
So really focused just on that aortoiliac section.
Exactly. Kept it clean comparison-wise.
Did they give details on, like, how bad the blockages were?
They did. The average length of the narrowed part was about 3.9 centimeters.
Yep.
And before the stent, the average narrowing was pretty high, around 83%.
Wow.
And patients got, on average, about 1.8 stents. So sometimes one, sometimes maybe two or three.
Okay. And the third group, optimal medical care, OMC. What was that baseline?
OMC was based on the ACCAA guidelines from 2005. So standard practice then. It included prescribing silestazol, that drug we mentioned,
Right.
0.100 milligrams twice a day, if the patient could tolerate it. They also got advice verbal and written on doing exercise at home, dietary changes, stuff like that.
And risk factors, like blood pressure, cholesterol.
Yeah, managing cardiovascular risk factors was definitely part of OMC. The study tracked those things and let the sites know, but the actual day-to-day management was still handled by the patient's regular doctor.
Okay, so best medical management short of a procedure or supervised program. Now, the big question, how did they measure success? What was the main thing they tracked?
The primary endpoint, the main thing they were measuring, was the change in peak walking time, PWT.
Okay.
They measured this using a specific graded treadmill test, the Gardner protocol. Did it at the start, then at 6 months, and finally at 18 months.
And that shows.
It's seen as the most, objective way to see how much someone's functional ability improved. How long could they walk before that claudication pain really stopped them?
Makes sense. Objective is good. What else did they measure? Any secondary things?
Oh, yeah. They looked at a bunch of other stuff to get a fuller picture. They measured Claudication Onset Time, or COT.
When the pain starts, not when it stops you.
Exactly. How long until you first feel it. They also used pedometers.
Step counters.
Right. To see how much people were actually walking in their daily lives, outside the lab or the clinic.
Real-world activity.
Yep. Plus, they asked patients about their own perceived walking ability and used several quality-of-life questionnaires.
Which ones?
There was a general one, the SF-12, and then two specific to PD. The Walking Impairment Questionnaire WIQ, which focuses on how pain impacts walking, and the Peripheral Artery Questionnaire, or PAQ, which looks more broadly at how the disease affects life.
Okay, so they looked at treadmill performance, daily steps, and how people actually felt about their condition. Comprehensive. How many people stuck with it?
Well, they started with 119 randomized participants, but the study actually stopped enrollment early.
Oh, right.
They were having trouble recruiting enough patients. It was slower than expected. So in the end, 79 participants actually completed the full 18 months of follow-up.
79 out of 119, that's about, what, 71%?
Yeah, around there. A bit of a drop-off, which is something to keep in mind.
Definitely. Before we get to results, who exactly were they looking for? What were the inclusion criteria?
They needed patients with moderate to severe claudication, defined by that treadmill test, had to be able to walk for at least 2 minutes, but no more than 12 minutes, before the pain got too bad.
Okay, specific window.
And they needed clear proof from imaging of significant narrowing in those aortoiliac arteries in the leg causing the trouble. They even made people do 2 baseline treadmill tests to make sure their walking ability was stable.
Consistent baseline. Makes sense. Any major exclusions?
Yeah, people with critical limb ischemia, that's the really severe PAD with rest pain or sores, were excluded.
Right.
Also, anyone with other major health problems that limited walking for non-PAD reasons, or anyone with a complete blockage of the main artery from the kidneys down.
Okay, so focused on moderate to severe claudication from aortoiliac disease without other major confounding issues.
Got it.
All right, the results. 18 months later, what did they find?
Okay, here's the really interesting part for you. At 18 months, both the Supervised Exercise group and the Stent group showed really significant improvements in how long they could walk on that treadmill.
Compared to the medical care group.
Way better than the optimal medical care group, yeah. Let me give you the numbers. The exercise group, SE, improved their peak walking time by an average of 5.0 minutes.
5 minutes longer walking. That's substantial.
It is. The stenting group, ST, improved by an average of 3.2 minutes. Also significant.
Okay. And the OMC group?
Barely changed. An average improvement of just 0.2 minutes. Statistically, the improvements in the SC and ST groups were significantly better than OMC.
Wow. Okay. So clearly, doing something either supervised exercise or stenting was much better than just standard medical care alone for improving walking distance.
No question there.
But the million-dollar question, how did exercise compare directly to stenting? 3.2 minutes versus 5 minutes. Was that difference significant?
And this is maybe the biggest takeaway. That difference between the 5.0-minute gain with exercise and the 3.2-minute gain with stenting, it was not statistically significant.
Really?
Yeah. The p-value was 0.16. So based on this study, at 18 months, the improvement in peak walking ability was comparable between supervised exercise and getting a stent.
Huh. So hitting the gym, basically, was statistically just as good as getting the artery opened up in terms of how far people could walk on the treadmill later.
In terms of peak walking time, yes. That's what the data showed.
That is pretty surprising. What about the other walking measure, the Claudication Onset Time, when the pain started?
Similar story there. Both the SE and ST groups improved significantly more than the OMC group in how long they could walk before pain began.
Okay.
And again, comparing SE versus ST directly, there was no statistically significant difference between them for that outcome either.
So, across the board on the objective treadmill tests, exercise and stenting looked pretty similar in benefit after 18 months, and both were much better than OMC.
That sums up the treadmill findings well.
Okay. Now, what about those blood flow measures, the ABIs? You'd expect stenting to win that, right?
You would, and it did. There weren't any significant changes in the ankle brachial index in the OMC group or the supervised exercise group.
Okay.
But the stent group, they had a significant improvement in their resting ABI. It went up by an average of 0.29, which was highly significant compared to the other two groups.
Right, that makes physical sense. You put in a stent, you improve the flow, the ABI goes up.
Exactly. It shows the procedure did what it was supposed to do hemodynamically.
Okay. But the walking didn't improve more despite that better blood flow number. Interesting. Now let's shift to how people felt, the quality of life stuff. That's where you said things looked a bit different.
Yeah, this is where it gets nuanced. Even though the treadmill walking improvements were similar between exercise and stenting, the patients who got stents reported greater improvements and more durable improvements in most of the quality of life scores that were specifically about their PA.
So the WIQ and the PAQ questionnaires we mentioned.
Exactly. On those disease-specific measures, the stenting group generally reported feeling better and being less limited by their PA compared to both the exercise group and the OMC group.
Even though they weren't necessarily walking further on the treadmill than the exercise group.
Correct. That perceived benefit, that quality of life improvement related to the PA itself, seemed stronger or more sustained in the stenting group.
But not on the general health survey.
Right, that difference didn't carry over to the generic SF-12 scale. It was specific to the PAD-focused questions.
That is fascinating. So, objectively, similar walking gains, but subjectively, the stent group felt their PAD was impacting them less. Why? Any theories?
Well, the expert commentary on this study by Anthony Camarota kind of highlights this. He points out, again, that this is aortoiliac disease, potentially more disabling.
Right.
And that stenting there often works well long-term. He frames the study as really trying to weigh these options in this specific context.
And did he address that mismatch? Better perceived quality of life with stents, despite similar walking?
He did, and the study authors themselves talked about this kind of paradox. They actually cited another study by Henney and colleagues, which suggested something interesting.
What's that?
That sometimes patients who have a revascularization procedure, like stenting, might subjectively overestimate how much their walking has actually improved.
Like a placebo effect for the procedure itself?
Yeah.
Or just feeling like it's fixed?
Could be something like that. A psychological boost, maybe? The feeling that the blockage is gone might lead to a greater reported sense of well-being or function, even if the objective treadmill numbers are similar to what exercise achieves.
That makes a certain amount of sense. The intervention feels more definitive, perhaps. Okay, let's not forget the limitations. We mentioned the smaller sample size.
Right. Definitely the biggest one. Early termination due to slow enrollment. That's always a challenge in these kinds of comparative effectiveness trials.
Why is it often slow?
Could be many reasons. Sometimes doctors have strong opinions already, or patients do. Reimbursement issues can play a role. Maybe insurance covers one thing more easily than another. Makes it hard to get people to agree to be randomized.
Got it. And the dropouts. about 29% not finishing 18 months. That could also skew things.
It potentially could, yeah. You always wonder if the people who dropped out were different in some key way from those who stayed in.
And what about the pedometers? Why didn't improved treadmill walking translate to more daily steps?
Yeah, that was another interesting point. The researchers basically suggested that, just because your legs can walk further doesn't automatically mean you will walk more in your daily life.
Habits are hard to change.
Could be habits, could be other health issues, motivation, environment. Lots of factors influence real-world activity beyond just leg capacity.
Okay, so let's try and synthesize this.
Oh.
If you're listening and you have aortoiliac claudication, what's the main takeaway from CLEVR?
I think the big message for you is that CLEVR gives us pretty strong evidence that both supervised exercise and stenting offer real, significant, and lasting benefits compared to just optimal medical care alone.
Right. Both improve symptoms, both improve walking distance for at least 18 months.
Definitely. They both move the needle significantly in terms of function.
But then there's that nuance, isn't there?
There is. While exercise achieved comparable, maybe even slightly better on average, objective walking gains on the treadmill. Stenting seemed to lead to a greater perceived improvement in quality of life, specifically related to the PAD. Patients felt better about their condition after the stent, even if their walking distance wasn't objectively superior to the exercise group.
Okay, so treadmill results look similar, but patient-reported outcomes favored stenting a bit.
That's a good way to put it.
Which leads to a final thought, really. If you're considering treatment, what does this mean? It suggests maybe the decision isn't just about maximizing walking distance on a test, right?
Exactly. It brings up questions for you to think about. What matters most to you? Is it purely the objective walking number? Or is it also about your subjective feeling of well-being, the perceived impact on your life?
And practical things, too. Like, can you actually get to a supervised exercise program 3 times a week for months? Is that feasible?
Right. Access is huge. Personal preference matters. How much is the pain bothering you day to day? All these factors, beyond just the treadmill PWT, need to be part of the conversation between you and your doctor.
So the provocative thought is, how do we best weigh objective function against subjective quality of life, access, and personal preference when choosing a path for aortoiliac claudication? And what more do we need to learn about the really long-term impacts?
Precisely. What happens beyond 18 months? What are the patient experiences years down the line? CLEVR gave us valuable insights, but the conversation continues.
Indeed it does. Well, thanks for taking this deep dive with us today. We hope breaking down the CLEVR study helps you understand the options and the evidence a bit better if you're navigating aortoiliac PAD.